This is a 2019 Jeddah scenario. With a recent
Can I
exam
see
scenario.
can I see the other picture, the front view once more if it's, yeah, okay.
I'll keep a timer for 3 minutes. Is it fine, Dr. Faiza?
I have kept already.
I think you've kept. Okay, fine. Hello.
Hello, Dr. Faiza.
I had noted myself. I totally forgot. Yeah, I have unmuted. Can you hear me?
Yeah, now we can hear you. Yeah.
So I can see an infant present in the hospital setting, having a cannula in his left hand and with the plastic tape in his with the sticking on the right foot. He is morbidly obese with the characteristic puffiness of the face, and uh, uh, gynecomastia is also there, and also uh, obesity is also there. So, and in the other picture, I can see hypertrichosis of the back, and the rest is under marker. Yeah.
So what is the questions that you will ask in the history to this patient?
Yes. First of all, the exposure to any exogenous androgens in the form of, for example, diaper rash cream, which contain excessive amount of steroids, or any history of the second question would be duration of these symptoms. I mean, these obesity, the way it has presented. And the third thing would be birth history. Birth history in the form of like any hypoglycemia, electrolyte imbalance after birth, and also appearance of the adrenals, I'm sorry, genitals during the examination. Yeah. And also if if the child is on exogenous steroids, would like to ask about the history regarding the side effect of these steroids, which would include diabetes, blood pressure, and yeah, that would be it.
And what will you see in the physical examination of this child?
Yes, in the physical examination, first of all, I would like to do the eye examination to rule out corneal haziness. I would like to see for, I mean, alopecia. I would like to see the, I mean, as seen in the picture, puffiness on the face, like increased add of fat. The distribution of the hair, whether it is hypertrichosis or hirsutism. And then would like to see the
What do you
gynecomastia.
feel it's over here? Is it hirsutism or hypertrichosis?
Hypertrichosis, not hirsutism. Yeah. And then abdominal stria, and also
between hirsutism and hypertrichosis?
sorry.
What is the difference between hirsutism and hypertrichosis?
Hirsutism is the presence of hair typical in the masculine distribution, like having mustaches or beard. And hypertrichosis is excessive amount of hair all over the body. Yeah.
Anything
And
else?
yeah. And also for a point of care, random blood sugar, point of blood pressure at that blood pressure, auscultating the chest for any V's, and also checking for myopathy in the muscles. Yeah.
Very good.
And skin stria and bruises, and any nail changes. Yes.
And what are your differentials for this case?
The first thing which would come to my mind is Cushing's disease.
What is the difference between Cushing disease and Cushing syndrome? Why are you saying this is Cushing's disease?
Yeah, Cushing syndrome is basically a triad of, not the triad, like it's the presence of, well, I cannot differentiate between that, sorry. The second possibility, either Cushing disease or Cushing syndrome, I'm very sorry. The second possibility would be obesity.
Okay.
And the syndromes related to obesity, like Prader-Willi syndrome, but it can be ruled out because the facial appearance doesn't go in favor of Prader-Willi. The second possibility can be mm, Bardet-Biedl syndrome, but that can also be ruled out because they would be having any polydactyly, and they would be having vision problems, which is not visible here. And they would have characteristic facial features which are not present. So these would be my differential diagnosis.
Do you know of any other endocrinological causes of obesity?
Hypothyroidism.
Okay. And?
Growth hormone deficiency.
Very good. And?
And congenital adrenal hyperplasia. I'm not sure about whether it's associated with obesity or no.
No. Pseudo-hypoparathyroidism.
Yeah, pseudo-hypoparathyroidism.
So how will you manage this case?
I would like to take a detailed history from the parents' point of care history regarding the duration, onset, and any systemic
We
manifestation.
covered the history and physical examination. Now beyond that, how will you go ahead?
Yeah. Okay. So I would like to run some basic tests involving my consultant, which would include the CBC complete blood film to rule out.
Complete blood count showing Cushing's syndrome. If this is Cushing's syndrome,
I think that WBC count would be the neutrophil count would be less. Yeah.
6 minutes finished, but you can continue.
Yeah.
And other tests?
Serum electrolytes.
What will you see in the serum electrolytes? In Cushing's?
Hyponatremia can be there. Hyperkalemia can be there.
Why will there be hyperkalemia and hyponatremia and Cushing's syndrome?
Yeah, that's wrong. I'm sorry. The third thing would be random blood sugar, which can be high. X-ray chest to rule out any respiratory causes of like obstructive lung disease. And then these endocrinological tests, which would include T4, TSH, and then this 21 hydroxylase, and then
yes, it's a good effort, but just let me know that if this is Cushing's syndrome, then which test will you do? You're suspecting Cushing's, if your consultant is suspecting Cushing's.
I think dexamethasone,
correct.
Cortisol level and dexamethasone suppression test, either in the low dose or in the high dose.
Very good, low dose, high dose dexamethasone. Cortisol levels, can you measure randomly?
Yes, can be measured. Because in
is there any use of measuring cortisol randomly? I'll do 2 p.m. cortisol. Now I want to do cortisol. Is there any use?
The cortisol level has a circadian rhythm. Like early morning, it's high, and in the night it is low. But in Cushing's, this rhythm is totally disturbed. So it would be like the same all over. So there won't be any point of doing it.
Yeah. So random is of no use.
Yeah.
Basically, random serum cortisol level is of no use. So that's why we do. I'll cover that further. Okay, we'll cover that later. Okay. Any other investigations if this is Cushing syndrome that you would like to do?
This cranial
yes.
ultrasound
Not
But
ultrasound.
the child is big, so ultrasound is not possible. CT brain to rule out intracranial cause like a tumor, which might be causing all these
For a
things.
tumor, which will be the best modality?
Uh, if it's a tumor, then I think
MRI?
yeah, MRI.
Where else the tumors can be besides the head? In
Um, um,
Cushing's.
in the adrenals.
Very good. So, CT
Supervising.
of the abdo can also be done. How
Yeah.
will you manage this case?
The management would be according to the cause. If it's a systemic disease in which the steroids have been used, we have to adjust the dose,
Very
and we
good.
have to manage the complications of these excessive steroids, like blood sugar and blood pressure and dietary modifications. But if it is basically Cushing's, then you have to give high dose, hydrocortisone. Yeah.
In Cushing's, why will you give hydrocortisone? As it is, there is so much of steroid in the body. Why will you add on to the steroid load?
I have no idea.
Okay, okay. No. Even I had no idea till morning. No issues. So, will you involve any multidisciplinary team?
Yes, it would involve, first of all, the primary pediatrician, the consultant, then an endocrinologist, then a nutritional therapist, and then psychosocial support,
Very
and
good.
also a dietitian to modify the diet. And
Mhm.
that's it.
What are the complications of Cushing's?
They can cause cataract, can cause morbid obesity, it can cause gynecomastia, it can cause high blood sugar, it can cause diabetes basically. Then it can cause myopathies, then it can cause like osteoporosis, uh, then increase susceptibility to infections because the children, their WBC count gets decreased, and then
Okay.
yeah.
I feel that's what. Any idea what is pseudo Cushing's?
No.
Thank you. Thank you very much, Dr. Faiza.
Yeah.
It was a very good attempt, Alhamdulillah. This is just, it has come, I think, once or twice in the past 1 or 2 years. But this is one place which I feel, just knowing some back, if we do not, if like, even in the morning I was reading, not revising the background knowledge, kind of an extempo presentation becomes difficult in this case. So I will just modify a few points that you said and add some extra points. So this is a Cushing's syndrome, as we can see, and the points that you mentioned in the examination were while examining the by mentioning, sorry, the clinical findings were absolutely right. That there is hypertrichosis, there is puffiness of the face, there is hirsutism, there is gynecomastia, there is basically truncal obesity, IV line in situ. The other was probably another IV prick that was given. So what would you like in the history? Always we could, preferably start the history with the onset, duration, and progress. That covers many things. So starting with the onset, duration, and progress. Now, most of the histories, like I have divided this, that we ask for the history of the symptoms that are there. Okay, the symptoms, then the history of the etiology that you can find, and the history of the complications. Whenever we are asking history for any case, CNS case or any case, if we just follow this pro forma, things becomes very easy. Like if this is a Cushing syndrome, like we know, or a kind, we can just put this as an obesity. So what are the symptoms of Cushing syndrome and obesity? Okay, those histories we ask, like what is the history of onset, duration, progress, we have finished. Then if there is any history of obesity, since when did it start, history of puffiness that is there, then what are the other symptoms that you can have with obesity and Cushing syndrome? So skin changes, did the mother notice any skin changes? Did the mother notice any bony weakness, okay, or any bony fractures that have occurred? What are the other symptoms? There is myopathy. So any difficulty in going upstairs and downstairs that the mother has noticed. Okay, then we can think about history of etiology. Now, if this obesity, as we know, is because of Cushing's or any other thing, we should start with etiology. We'll ask about the diet history. I think you mentioned about the diet history. So the diet history, I'm going to ask about this. I'll ask about the growth history, because how the growth is will give me a very good diagnosis. If the growth is less, the height is less, it goes into an endocrinological cause of obesity. Okay, but if the height is more, then it is a simple obesity kind of a thing. So when I will ask for the growth of this child. The other etiologies of this kind of obesity after diet, after this can be any medication history, which you rightly asked, that any steroid that the child has been taking. And if there is the medication comes positive, then I'll ask for any other chronic illness. Means, does the child have nephrotic for which he is taking so much of steroid? Does the child have an underlying asthma for which? So I will ask an underlying chronic illness history to rule out any other chronic illness for which these steroids have been taken. Other etiology of Cushing's syndrome besides iatrogenic is tumors. Tumors either in the pituitary or tumors in the adrenal. So for tumors in the pituitary, what will you ask? So I will ask history for headache, any vision loss, any vomiting. Okay. So these in history. And the other complications that can occur because of all this, because of the obesity or because of the excessive steroids, as I told, skin bruising, then growth arrest, all that has been, that's a bit of overlapping. The skin changes, the bone changes, and the growth arrest. So basically, these are the things that you will ask in the history. To just, I will once again summarize: onset, duration, progress of this illness, then facial puffiness, skin changes, bone changes, okay, that have occurred, then weakness while going upstairs or downstairs, medication history in detail, chronic past any illness in the past, so past history that will be taken, diet history very much in detail that will be there, and history of any other etiology, like I told about medicine intake. But if there is a tumor that can cause the Cushing syndrome, then history of headache, vomiting, and vision loss. Vision. Okay. In physical examination, Dr. Faisal, just one main thing you you told it's obesity, but did you see I will plot the child on the centile chart, plotting the side for height, weight, BMI, very important, right? So that our performance, our template is with us. So first we'll do the centile, then second we'll go for the blood vitals. Mention everything: temperature, heart rate, RR, blood pressure. I will measure especially the blood pressure. Then from because this is a general case, so just as you're going for a general case thing, what we will do is we'll do the skin examination to see for any stria, for any bruises, any atrophy, skin atrophy, okay, hypertrichosis, hirsutism, acne, or pigmentation. If there is an ACTH releasing tumor, then there will be pigmentation. Once skin is done, then what we'll see, head, we are not going to see anything. You said alopecia. Why, when there is hypertrichosis, how come alopecia will come? Now that I was just kind of wondering. Then you go into the eyes.
Alopecia is like when you use excessive steroids, you have hair loss from the head. But that is mostly in teenagers. That was wrongly said here, but sometimes like alopecia can occur.
Okay, then I'm so sorry, I'm unaware about that. I was unaware.
No, but that occurs in teenagers, not in this age group.
Okay, I'll read up about that.
So I was wrong.
And eyes, you said corneal opacity. Will we see for corneal opacity or we'll see for cataracts in steroid excess? We'll see for cataracts, right?
Okay.
And because there are subcapsular cataracts as far as I know. And for the other causes of obesity, okay, even that I think Prader-Willi, Lawrence Moon Beadle, even they have. I see. I have my notes of Lawrence Moon Beadle, and this they also have.
Prader-Willi have no eye changes. Barrett-Beadle have eye changes. They have eyeglasses and these problems.
Prader-Willi just has these almond-shaped eyes.
Yeah, nothing else, nothing in the eyes.
So that's why we're at least no corneal opacities as far as I know. Neither the pseudo hypoparathyroidism or hypoparathyroidism have any these changes. Okay, so we will avoid telling about corneal obesities because mucopolysaccharidosis, which does not present like this. Moreover, right? There's retinal degeneration in Bardet-Biedl. Okay, fine. So the other examination that you told polydactyly, and we can even yeah, that's face changes. We can say okay, face changes like puffiness and everything. I will examine. You said that. You said about obesity also. You just very nice thing you said was proximal myopathy, and very excellent thing that you said was wheeze, because it a quite big possibility this is an asthma which is being taken oral steroids. So at this so that is a very good point that you said, you know, you said about wheeze also. In fact, I did not have that point. I've written it. So your differentials, as you rightly said, this could be a Cushing syndrome. And then I asked you that what is the difference between Cushing syndrome and Cushing disease? While Cushing disease is specific, it is only to the which point is that, please? I said a good point which Dr. Faiza said was wheeze in the chest to be seen, so that we come to know whether this was asthma for which steroids were taken, and the child has presented with this kind of a picture. Okay, so very nice point she said. And now what was I saying? Okay, Cushing's disease. What is Cushing's disease? Is very specific cause of Cushing syndrome. Cushing syndrome has everything. Okay, but Cushing disease is only that cause where there is ACTH release from a pituitary adenoma, and after that the Cushing syndrome is taken place. That is Cushing disease. Whereas Cushing's syndrome is everything. It is in excess of steroids, excess of ACTH, excess of everything. If you could just give me a screen share option, Dr. Noor, I will just kind of, you know, explain. I could be able to explain in a better manner.
Want to write on whiteboard?
On the whiteboard.
So Cushing disease is basically, I mean, it's from the pituitary and
adenoma releasing ACTH. Okay. So let me just see if I could write on this. 1 second, Dr. Noor is disabled. I think the recording problems occur if she makes me the host. So Cushing disease means only it is the Cushing syndrome because of release of ACTH from the pituitary adenoma.
Try writing here. You cannot write.
Just let me do. Okay, I'll just try. How do I start writing? By share screen, I should write. I should go to share screen, right? And then it's coming. Host has disabled participant sharing screen.
There are three things: Cushing's reflex, disease, and syndrome. Yeah.
You can write, but I can't. I think, Dr. Fatima, I will. Okay, Dr. Fatima, could you please write for me on the top? If you just write Cushing syndrome,
you will have to change yourself as a host, then you can write, Dr.
But then the recording will be a problem. I don't want the. Then make two arrows, one on the left, one on the right. Very good. One on the left, the other on the right. On the left side, if you could just put ACTH dependent. Dependent. Just put plus. And the other is ACTH independent. So, Dr. Faiza, if you could just tell me from where can we get more of ACTH? There are only two places, either pituitary or ectopic, right? So if it is ACTH dependent, you're getting excess of ACTH from the pituitary. So this is the first is pituitary. So it's most probably a pituitary adenoma. So this one is the Cushing disease, which I'm talking about. Okay.
Yeah. Okay.
Now ACTH dependent means pituitary. The ACTH coming from other place. Besides the pituitary, it can come from carcinomas. So just write, Dr. Noor, ectopic sites. So ectopic sites can be like the small lung carcinomas or pheochromocytoma or thyroid. You know, they can sometimes, the ectopics can release ACTH. These carcinomas, these cancers can release ACTH and in turn cause Cushing syndrome. Now, ACTH independent means the ACTH is absolutely normal. What is being released is the excessive steroid. So from where can this steroid come? Either from the body, endogenous, okay, or exogenous, EN or EX. So exogenous we all know, and this is the commonest cause of Cushing syndrome in children, the exogenous cause, that is taking iatrogenic steroid tablets. And I was just going through Google, even intranasal steroids at times and other kind of steroids can cause severe Cushing syndrome. So this is the most common, okay, the exogenous form. And from
But,
where does
I have a question, Dr. Muzna. Like you said, ACTH dependent, in which there is going to be either from the pituitary, and then there would be ectopic. So the ectopic one would also be resulting in Cushing's disease or Cushing syndrome.
Cushing syndrome, that will be syndrome. Disease is only the pituitary adenoma releasing ACTH.
Okay, this cornermost one on the right side.
The good pituitary that
Dr. Faiza, just remember, Cushing disease is central. Okay,
because
and Cushing
I
syndrome
always
is
have this
peripheral.
confusion. Okay.
Cushing syndrome is peripheral. Cushing disease is central. Central is our brain. So anything problem in the brain, not only ACTH, there can be CRH. Okay, at the level of the hypothalamus. So if there is any problem there, there will be Cushing disease. If there is no problem there, then there will be Cushing syndrome. Either ACTH coming from carcinoma somewhere ectopic, or you are giving the steroid from outside.
But this just one thing, that this Cushing syndrome is a spectrum which covers everything, right, Doctor? I think Dr. Rohel is the one who's talking.
Yeah.
Okay. Oh yeah.
Yeah.
So Cushing syndrome is a spectrum which covers everything, whereas Cushing's disease is specific for the pituitary, ACTH releasing pituitary adenoma, as far as right? Fine.
Yes.
So ACTH independent, exogenous we covered, like the medications, and endogenous, where all can the steroids come from? If we guess, adrenal adenomas, adrenal carcinomas, So these are the ones which will be endogenous release, adrenal adenomas and adrenal carcinoma. So this is just a background knowledge for us to be confident, but it will not be asked in the video station. I've just written all this so that we can understand the further tests also. Then investigations and complete blood count, you said there will be a decrease, neutropenia. But as far as I know, it's leukocytosis that takes place. There is raised WBC, and that is always, we also say there's reactionary WBC that has been raised because of the steroids that we given many times, So that is raised. RBS, you rightly said. Electrolytes, you just said the vice versa. When you're giving steroids, even mineralocorticoids are going. So what will mineralocorticoids do? They will retain sodium, reduce potassium, and release the potassium. So it will be hypernatremia and hypokalemia. So mainly you should see the sodium and potassium to see for the low. I will see for serum electrolytes to see for hypokalemia. You should be seeing, okay. And because there is hypokalemia, the body, when it tries to retain the potassium, it even tries to lose hydrogen ions, because it wants to sometimes save potassium. So there's metabolic alkalosis that takes place, because the hydrogen is lost to save whatever little potassium that the body has. So there is metabolic alkalosis and reduced potassium that will use it. 24-hour urinary free cortisol, where you can just mention these tests, because I have just read and I've understood these tests, but to explain in the examination is going to be damn time consuming. So at least remembering the name, towards the end we'll discuss what is the interpretation of the test, but right now I'll just tell the names of the test, okay? So 24-hour urinary free cortisol, what will happen to that? That will be increased, okay, more than the 3 times the upper limit, that will be increased. Low dose, as you rightly said, low dose dexamethasone suppression test and high dose dexamethasone suppression test. So low dose is to know whether it is Cushing's or not Cushing, and high dose is to know what is the cause of Cushing. Understood this point? Should I repeat it? Low dose dexamethasone test, just in a nutshell, if the examiner asks, it is to know whether it is Cushing's or a normal child. And high dose to know what is the cause of Cushing. Is it ACTH? Is it steroid or endogenous steroid, like this? What we have, Dr. Noor has drawn over here. To know what the cause is, we do high dose dexamethasone suppression test. Now there's this screening test which is very reliable, which has come up, is late night salivary cortisol measurement test, okay, or midnight cortisol measurement. That is there. In the midnight, you take the cortisol. Generally, it should be means as we discussed, it should be low, and that loss of diurnal variation takes place. So this is a very effective screening test: late night salivary cortisol measurement or midnight serum cortisol level. Midnight serum cortisol, although they say the child should be relaxed, should be sleeping, but when you prick the patient, I don't know how will he be relaxed and how will he be sleeping. That's the only disadvantage of this test. Okay. Then investigations, you told MRI of the pituitary, right?
Is it a salivary test, midline saliva or blood?
Both are there.
Both.
Both are there. That's why the disadvantage of the serum midnight serum cortisol is that sometimes the diurnal variation may get lost because you are waking up the child and you are putting him into pain, and the excess steroids may get, that is what is written sometimes, but still in the screening test, the salivary cortisol late night or midnight cortisol level, both of them are the adequate screening tests. MRI of the pituitary, you rightly said. CT scan of the abdomen or the chest, chest, like as I told you, small cell carcinomas can also release ACTH. So that is why the chest CT. Then I told you adrenal adenomas and carcinomas can also release steroids. So CT of the abdomen, right? So you covered those points. And regarding the management of Cushing, multidisciplinary, I will first tell the treatment so that you
Hello.
understand. Dr. Noor could mute.
Please mute. Please mute.
Dr. Noor, please mute everyone.
ഞാൻ അകത്ത് എഴുതി വെച്ചിട്ടുണ്ട്.
Okay, Jazakallah khair. So then management of Cushing's, once we understand, we'll understand the multidisciplinary team. So if, as she rightly said, there's an exogenous steroid, the steroid dependence needs to be weaned off. Okay, it needs to be, okay, why CT chest? In order to see whether there are small cell, that's generally in adults, to see for small cell carcinomas which are releasing ACTH, for the ectopic ACTH dependent Cushing syndrome, for that. So definite treatment, where was I? Okay, so as you rightly said that exogenous steroids, if they are being administered, we need to wean off for the steroid dependence. You can even add a point, you can, if there is any disease which requires steroids, so a steroid sparing drug can be added, okay, so that the steroids are weaned off and this is taken into consideration. Then if there is a tumor, like most of the other causes are oncology causes, so the resection of the tumor is very important, okay, so tumor resection, that is a definitive treatment. Then before tumor resection also, we need to reduce the activity of these drugs in the body, steroid drugs, which are steroids which is going on. You cannot just all of a sudden remove the tumor and there is absolutely no steroid in the body. So before that, you need to acclimatize the body, normalize the body. So you have to give drugs like metyrapone, ketoconazole, and mitotane. I think you even remember ketoconazole or other drugs in order to reduce the steroid levels in the body. That's fine. It's not going to be that bad. And if at all, sometimes radiotherapy is having a role. Okay. So in that form, you can form the pediatric multidisciplinary team. What will be there? There'll be a pediatrician, there'll be a pediatric surgeon. If there's a tumor, there'll be an oncologist and an oncosurgeon and a radiotherapist. An endocrinologist definitely will be involved for this case. And to just complete the rest, a social worker we can add. Complications, you covered everything very nicely. And pseudo Cushing's, I was asking you, that can be added as a differential for Cushing. I was just reading today, I didn't know about this. This group of conditions, which have clinical as well as biochemical features of Cushing syndrome. Means when you see them clinically, you see the results, you feel it's Cushing's. But the hypercortisolemia is usually not due to Cushing's, it's secondary to other factors. So before labeling anything as Cushing's, you should rule out these causes like obesity, depression, stress, PCOD, diabetes, uncontrolled diabetes, or alcoholism. So you can go, we can get all this on the internet, no issue. So what is going to actually differentiate pseudo Cushing from Cushing? Once again, the same test, midnight serum cortisol test. Okay.
Yeah, there was a very nice discussion. Actually, the thing is that always this endocrinology is a bit.
Endocrinology is extremely. In fact, I even have left still. You know how if the examiner actually they will not give you an endocrinologist. You know, otherwise he will ask how will you interpret the high dose dexamethasone suppression? How will you interpret the low dose dexamethasone?
No.
But
Jeddah, they have very good
it's
endocrinologists.
toxic for everyone. So
Jeddah
I will
have.
not touch that. Just say low dose to know whether it is Cushing's or not Cushing's, and high dose to know the cause of Cushing. Is it ACTH or is it steroids? I
Okay,
think
one
that
more
much will
thing.
be
Yeah,
enough. If
Dr.
anybody
Muzna,
wants
one.
to share my notes with
Yeah,
Dr.
I just
Noor,
want another question was now, if you said treatment of the cause, if it is Cushing syndrome, okay, like
yeah,
steroids disease treat with a disease modifying or taper the dose of steroids. But if
yeah.
it is Cushing disease, and
Hmm.
I said that give steroids, and that was a wrong answer. So what is the treatment for the Cushing's disease?
Cushing disease is because of a tumor. So tumor
Ah,
resection.
okay.
And before
So,
the tumor resection, also you need to normalize the body. So you have to give these drugs like ketoconazole, metyrapone, and yeah, mitotane. Yeah, mitotane.
okay. Yeah, I mean, where it is given, patient info, it's
Patient,
given
patient,
nicely or somewhere else.
patient. Patient info very lengthy. I'll do one thing. I will give my notes to Dr. Noor. She can inshallah circulate it.
Yeah.
I
Or
want
just take a screenshot of that paper where you have written something and just put it in the group if it's possible.
Yeah.
Thank you. But thank you very much for the healthy discussion. And thank you very much, Dr.
Yeah.
Noor, for the chance.
And if it goes into obesity, like now, Dr. Faisal, could you help me? Like if she's okay, come on, now, if this discussion goes towards obesity. So what are
Yeah.
the causes of obesity that you know of? Like how will you go with the obesity kind of?
Obesity, they will ask you like the question define obesity. Then you have to differentiate between the moderate obesity or severe obesity. Okay. If they
You
will
said
ask
this
you,
is, you told me
huh?
this is morbidly obese. I have written that, but did you know what is the centile chart? I did not ask.
Yeah. The centile chart is, I think if it is more than 96 centile, it
No.
is morbid obesity. And if it is on the 90th, obesity
Morbid,
is 90, no, 90th centile is obesity. 90th centile. It's
No, no,
written very
no.
nicely in the,
91 is overweight,
yeah.
98,
91,
91
Dr.
is
Muzna,
obesity.
91 to 98 is overweight. More than
Yeah.
98 is obesity. More than
Okay,
99.6
99.6 is morbidly obese. That's why I was
morbid
saying
obese.
you follow the centers like that
Yeah.
make like that. Just say obese, just to be on the safe. Because if the examiner becomes
Yeah.
means he
No,
loses
it's
his
very
temper
nicely
and
given in the guidelines. It's very nicely given in
yeah,
the guidelines, these definitions, na?
guideline.
And what about short stature? How will you define short stature?
Less than the third centile for the growth appropriate
For
growth
the
chart for the child.
less than the second centile for the age,
for the age
for
and
that
sex.
age. Yeah, age and race. Yeah, not the third.
Second or
And
fourth, I don't know. I'm not sure.
Second. It's second
second,
centile.
second sentence.
So, and if
Second.
it's
Second sentence.
yeah, if it is obesity, they will ask you how to what is morbid. What is morbid, what is obese, they will ask you. Then they will ask you what are the causes.
Yeah, second.
Causes is basically they're asking you about the history. Then you have to think of all those things like dietary factors, and also you have to ask about the duration of obesity. Like if it is less than 5 years, then it is associated with any syndromic manifestations. These two things you have to ask. Okay. And the third is familial. If it is obesity is occurring in a child who is less than 5 years old, then it is definitely a like endocrinal cause or a syndromic cause if there is association. Okay, obesity which is familial mostly occurs at the teenage, like the family history is there and uh, dietary history is there. So this is the important thing is there. Okay, and the third thing is that, and then the how will you investigate? Then the investigations for obesity.
If the examiner asks you which is one thing in a obese child which you would like to know whether this is a simple obesity or a pathological obesity. One thing I want you to ask the child, or I want you to examine in the child, which will help you.
Tall or obese, short or obese?
If
Mental
it's tall or
capability
obese,
should
it's
be
a
asked.
simple.
Also, mental
Huh?
capability.
Yeah, tall or obese, short or obese, because most of the endocrine causes
Most of
or
endocrine,
syndromic
most of
causes
the genetic also, they all go into
are
short
they
and obese.
short and obese. And most of the nutritional causes, they grow into tall and obese.
Dr. Krishna, you are speaking in the reverse way.
Most of the nutritional are tall and obese. Most of the endocrine are short and obese.
Yeah.
What is left is genetic, and for that, as Dr. Rohil rightly said, asking for the mentation, intellectual disabilities, and other associated history. So if whenever in the
Suppose,
video station, yeah,
suppose there is
please
a
go
case
ahead,
of
Dr.
hypothyroidism, it will be short and obese. Hyperparathyroidism, short and obese.
Growth hormone
So
deficiency, hypoparathyroidism,
short and obese. So the height, the bone age, the
Over here,
chronological age.
if Dr. Krishna, if you are going for obesity, always ask when they start notice this one. Always ask. Onset, course, duration should be in your mind. Then you should
Regarding
ask about the
yeah.
diet history, ask about the screening time, daily how much screening time is there, mentality or learning disabilities. Then you can ask even unusual features. If you think that she is not looking like you or your husband, mother can tell you. It's not a problem. If you want to ask that you can explore further. And
Yeah,
short
what
and
all?
tall. Short and tall.
Yeah,
These are the 5-6
short.
questions which we
Yeah,
have to ask.
and yeah, the histories we have to explore is the dietary history, the drug history, the screen time history, the outdoor activity. I think at least 1 hour per day or 30 minutes per day.
20
Outdoor
minutes.
activity, 20
At
minutes.
least more than 20 minutes. The good is 60 minutes.
Yeah, the 30 minutes we can at least we can 1 hour. Yeah, 1 hour we can outdoor activities, and yeah, this screen time should be avoided, and yeah, any bullying at school, all this history should be included, and the familial history. I think more than enough.
Dr. Krishna, what is the meaning by screen time? Sorry, I don't know. Would you
Screen
elaborate?
time is like the children's nowadays they are
Watching TV,
most of the time
watching TV,
TV,
tele or mobile or something. Anything they're doing, watching the screen.
screen.
Yeah.
At
that
when
One
I
thing more in obesity is the chart, BMI chart. Can anybody tell how we plot BMI chart?
90
Yeah.
pink for the girls, blue for the boys, more than
It itself
91.
is a
No,
separate
we know
section.
values, but we know values because in exam
Not like this.
sometimes they
Not
are
like this.
giving
You
the
have to,
chart, growth
Just
chart,
a
BMI
second.
chart, and they are
Just a
saying please
second.
plot this one.
Yeah. You
So
have, first of all, you
horizontal,
have to take the, just hold on. You have to take the, you have to plot the height
I will hold
centile.
on it.
Yeah, and you will plot the weight centile. Okay, you will
Yeah.
calculate those
Yeah.
centiles, and then you will plot them on the BMI centile.
Okay,
Mhm.
it itself is a separate session. We will do it, inshallah. Because
Yes, yes,
there will,
Before we
it
start
can come in
pulling each other's hair. Yeah.
yes.
Is that true, Dr. Faiza? Because I thought there's the on the x-axis there's the age, and the BMI calculated is on the y-axis, and then you plot, and then
Yes.
the centile of the BMI we
Yes.
come to know. Rohil, please
Yes.
help us with that.
Yes, see, Dr. Musna, they will give you each graph, each curve has its own centile over there written. Okay. On the horizontal, they will give you age. On the vertical, they will give you BMI. Just you have to plot and you will find where are you, not you, your patient. Then you can say that, yeah, my patient is falling more than 99.6. So is in morbid obesity. Like this, it's very simple and very convenient chart. Much more.
I don't think so. I don't think so. BMI. There is no separate chart for BMI, Dr. Krishna.
Yeah,
BMI
there are
chart.
separate. I will forward you, Dr.
There is separate chart for BMI. He is right. There
Yeah,
is chart of BMI.
I will forward you, Dr. Fazia.
And
Till the time I will keep on hold, and in the meanwhile I will
Faiza,
forward.
not Fazia, Faiza. Okay.
Fazia.
Careful with
Dr.
the names
Faz.
in exam. Okay. If you make mistake, it will undermark you, the names. And there is BMI chart, and I have with me. I can forward, but we will inshallah we will have a session of it, inshallah.
Yeah. In the exam, in my mock exam, Sally was the name of the girl, and I addressed, name of the boy, and I addressed him as girl. So, undermarked.
Dr. Noor, someone is asking for the link of your vision, mission, or passion, whatever you want to share. So if you could put that on the chat, please. So it
No,
is.
see now my vision group is full, I think, but I am not sharing link with anyone. They have to message me because some people they are joining in both the groups. I want to limit people to one group only because if everyone joins to both the groups, I have to create one more group. I want to keep these two groups only. So if anyone wants, they will message me personally and I will be adding them or I will be sending.
Message Dr. Noor personally, huh?
Okay.
Yeah. And I have seen many people, they join they advertise for Bitcoin and all. So better to add, like not to forward the link. Better to add personally.
Yeah. For Alhamdulillah, in my group, such messages are not there till now. If anyone
Yes,
messages, I will remove him immediately. That's
yes,
for
yes.
sure. But till now, I did not see any coin messages in my group.
Yes.
Alhamdulillah.
Bitcoin.
Okay. So I think it was
Yeah.
a nice discussion, but I had one question I want to ask Dr. Muzna. Ketoconazole, why ketoconazole is coming here? I did not understand.
Means these three drugs have this anti-steroid effects. That is
Ketoconazole is antifungal, right?
it does have. You seen the side effects also. It does have anti-steroid effects. I will share it on the group. Then inshallah, what's the mechanism of action presently? I just know the mechanism of action of ketone, CYP, this.
Okay.
But CY, there some dinosterose methyl is I don't remember this also, but it's not a dinosterol methyl is just anybody know the mechanism of action
Yeah.
of ketoconazole? It is I
It
think the
is. It is.
dinosterol.
Yeah. It is. Sometime it is prescribed for this. I do remember, but
Has a
uh,
this.
and that is something we
Anyways,
call as medical. Yeah.
it's mentioned in, you said in patient info, right? These three drugs. Hello?
It's mentioned in the patient info drugs. Everything is taken from patient info. And it is some 14 alpha steroid demethylase, and it does have this effect of inhibiting the steroid effects that is there. Exact mechanism of action, I'll put it on the group. I have not read that because I even felt that was
Yeah,
I
that's
think
not in my
Dr.
what it will
Muzna.
be asked in
I
the exam.
just
Dr. Muzna. Hello, Dr. Muzna. Hello. I think
Yes.
it is something called as medical adrenalectomy. Something, the term is something I remember.
Medical adrenalectomy means
Something like this. It interfere in the pathway of formation
and someone
somehow
has
with the
even written that itraconazole
enzyme.
causes
But
Addison's.
they will not go in the detail. This was the
I
Indian
just asked, I just wanted to know only. And another thing I want to ask Dr. Muzna, you said if this is a pituitary adenoma, releasing the ACTH in ACTH dependent, it is the only place where we call it as Cushing's disease. This is the only place, like I'm writing here. It is called Cushing's disease. Rest all it comes under Cushing's syndrome, right? Rest all these causes, other causes we described.
Actually, Dr. Noor, Cushing's disease also comes under Cushing's syndrome. So syndrome
Yeah.
is a large umbrella. Under that, Cushing's disease, the central cause, and all peripheral cause also comes.
So this is Cushing's disease is the central cause. That's all we will remember.
Yeah, that's it. That's it.
That's
Okay.
Yeah, actually, ketoconazole causing how it blocks adrenal 11 beta hydroxylase and 1720 hydroxylase enzyme. That's responsible for the rise of ACTH. So that's the reason it prevent the release of ACTH and cause. So that's the reason it is using in Addison disease, Cushing disease. This ketoconazole. It inhibits two enzymes that are necessary for the release of ACTH. So that's the reason it controls use in Cushing disease.
Yeah, that is known as medical, I think, some adrenalectomy. Medical adrenalectomy is the right word.
Check, no problem.
Yeah. And yeah, this see syndrome is something which you see apparently, the symptoms and signs you are seeing. So it can be because of adrenal gland, it can be because of the central cause, but these are the features you see. The Cushing disease is something which is coming from the brain, stimulating the adrenal to cause it. It is the cause. And Cushing's reflex is we call as hypertension, bradycardia, and increased intracranial tension that will come in space occupying lesion. So
Sorry, Dr. Krishna, it's irregular breathing, not raised ICP.
Raised ICT, hypertension,
No,
and
it's
bradycardia.
irregular. Is
Oh, sorry, irregular breathing.
irregular breathing. Sorry to correct you. Irregular breathing, hypertension, and bradycardia.
But it is the reason for this is intracranial
Raised
tension.
ICP, this showing by this triad.
Yeah, raised ICT is the causative or for this, and
It's
it
not
is
a part of his
irregular.
triad.
Not the
Showing,
part, but it is the
symptoms showing
etiology
that
of
he
this.
has raised ICP.
Etiology of this. Etiology.
Etiology, you can say.
Yes. Okay. Thank you very much.
Okay, I have only one last question. So you said for the brain, the choice of imaging is MRI for pituitary adenoma, and for the adrenal, it is CT.
CT for adrenal and chest for those other lung carcinomas.
That is lung carcinomas usually in adults.
Yeah, in adults.
Okay. I think our discussion was.
I think it is enough, and this much will not be asked. I think the Viva will go into more of the obesity history examination. However, if the person tells this Cushing syndrome, we should at least know the headlines. You know, this.
Dr. Siham Bashir, if you have my number, please message me. Okay, please message me on my personal contact. Next, I want to go with the cranial nerve lesions, but after this discussion, I think I need to take break for 20 minutes. We'll start at 2 to 3 p.m. Okay, we will do for 1 hour.
Okay, Dr. Noor?
I think I am bombarded. No, Cushing's syndrome. Okay, just 1 minute. Yes.
Just one point, Dr. Muzna mentioned before that we have to rule out some causes like stress, obesity, and depression. These causes, we can rule it out by the dexamethasone suppression test, the low dose. It will be suppressed by the low dose oral dexamethasone suppression test.
Cushing's, you mean the pseudo Cushing's causes, right?
Yes. Those we can rule them out by the low dose dexamethasone suppression test. So we can distinguish this between Cushing syndrome and this minor, pseudo Cushing, like stress, obesity, and depression. Then
the first choice is that salivary, serum cortisol midnight. The second was given as dexamethasone suppression.
Okay, now I think before it was dexamethasone suppression. This is new, this midnight salivary cortisol.
Midnight, late night salivary, midnight cortisol serum. That was why I don't know what.
Okay, the cortisol will be high on this. Also, the cortisol will be high on these occasions, but we can differentiate by the low dose dexamethasone suppression test. Then after that, when we rule this out, we can do the high dose dexamethasone suppression test to differentiate between the Cushing disease and Cushing syndrome.
Okay. So, Dr. Muzna, please, now I am confused. Now, what's the difference between this midnight cortisol test and dexamethasone? These are different tests, right?
Yeah, different tests. If you want me to describe that, that will take another 10 minutes.
No, I want to ask, in the midnight, this salivary cortisol test, you will measure the level of cortisol.
Yeah.
You'll see the dexamethasone suppression, you are giving the dexamethasone and checking.
Yes, you're giving the dexamethasone low dose. You generally give it, in the night 11 p.m. and see the 8 a.m. cortisol. In high dose, you first in the morning, you collect one serum cortisol at 8 a.m. 11 a.m. you give a high dose dexamethasone. Next day morning 8 a.m. you see the serum cortisone at 8 a.m. once again.
Okay. This midnight test, they are just measuring the cortisol level. One in the saliva and another in the blood. Two things.
Yeah.
Okay.
And it should generally be low, some 7.5 microgram per dl. That's the value. And if it is high, generally, then it's the Cushing syndrome.
Okay. Okay, if anyone has comments, can go ahead before we stop it for 20 minutes. Okay, no comments, so I will end the meeting. If anyone wants to post anything about these tests, and if they get a simple diagram or anything, you can post in the group, no problem. Okay, I'll just end the meeting.